Hello, I'm Dr. Daniel Griffin.
And I'm Dixon DePommier.
And today we will be discussing non-purulent dermatitis.
You know, I was hoping you would say that.
You were hoping? Okay.
Yes, because the last one was on purulent dermatitis. By contrast, what is non-purulent dermatitis?
Well, I know when we did our lecture on purulent dermatitis, you were quite upset by the word purulence.
Well, maybe not upset, but I certainly took it seriously.
And so now that it says non-purulent, I guess you won't take this lecture very seriously.
Well, I'm not sure. If I were a clinician, I heard, oh, don't worry, it's non-purulent.
Yeah.
Is that something that a clinician should consider, or does it also result in some serious manifestations?
You know, I'll say, and I start off this section by saying it's always challenging. It's always challenging for me, and I think it's always challenging for a clinician to identify or classify or diagnose a rash as non-infectious and non-purulent and just inflammatory, with quotes around the just inflammatory.
You mean like from a trauma or something like that?
Well, let's say from an irritation. I know you told the story at one point about a dye in a bathing suit irritating a young woman's
clothing
skin.
that fits too tightly.
And so is it that maybe they touched something, maybe they used poison ivy for a purpose it's not really designed for, or they touched something that they're allergic to, or there's been something that they've been exposed to that has caused the immune system to respond. So it's always a challenge, because when you say something is non-purulent, non-infectious, when you're thinking of an inflammatory rash, dermatitis, if you're wrong and you settle down the immune system, you may end up in a really bad situation.
You mean like immunosuppressing?
If you suppress it with something.
Got it.
And so one of the things that we might end up using if someone has, we think, a non-purulent or infectious, inflammatory dermatitis, we might use a topical steroid.
Exactly.
And that could be quite a problem if it's fungal, if it's a type of bacteria we didn't recognize going into this.
That's right.
So one of the things we'll just, as an introduction thing, I always worry more when I make the diagnosis of non-purulent dermatitis, and I always spend a bit more time educating them about how important it is to come back promptly.
Absolutely.
If things go awry.
Yeah, that's right. That's right.
Now, as far as clinical disease, this is very common. This is one of the things that, even though non-purulent sounds less upsetting than purulent, this can be very upsetting. It can have a major impact on quality of life. It can be miserable.
Yep.
So this is a frequent problem in, I'll say, all settings, whether it's a rich resource, well-distributed part of the world, or whether you're in a limited resource area. This is something that clinicians are going to have to be very comfortable with.
Got it. Food allergies, some of them fall into this category?
Sometimes they'll come in and they'll have this rash, they'll have this inflammatory skin condition, and it may be because of something they ate. In situations like that, clues might be symmetry and location. They may say, I'm itchy, I've got this rash everywhere, but it's worse maybe here, the antecubital fossa bilaterally. It may be behind the knees. The symmetrical full body rashes, non-purulent dermatitis, inflammatory skin responses, may often be due to a food or a medicine. This may be something you caused by treating them for something else.
Iatrogenic.
Well, not you. Not you, of course.
I love that word, iatrogenic.
Iatrogenic. No, some of the non-purulent, non-infective dermatitis may be caused by clinicians, caused by our medicines.
Right.
So the diagnosis here is going to be critical. You want to be very careful, even though you're thinking this is not something so serious, because being wrong can be devastating.
Right.
You want to look and determine, is this a primary process, or is there some other process going on?
Sure.
Once you've made that, is there a bacterial process? Is there a fungal process? Maybe it's a parasite that doesn't normally affect us, like we've talked about.
Yep.
Swimmer's itch, when we have our avian schistosomes trying to invade.
Exactly.
It may actually be the invasion of a human parasite, and we're seeing an inflammatory rash where the real issue is going to be down the road and deeper and more of a major issue.
Sure.
So you always want to be really careful in how you approach this, in the confidence in your diagnosis. And again, like almost all skin conditions, we make a distinction between localized uncomplicated and generalized complicated.
That's right.
Should I ask you, have you ever had other than your poison ivy story in the woods?
I'm trying to think. I'm not a hyperallergic type of person to begin with, so I've never had any food allergies that I know of.
Okay.
I don't think I've ever had any contact dermatitis due to new clothing or shoes that fit too tight or socks of the wrong color or something like that, which I know a lot of other people that I've known have complained about in their lives. To my memory, I would have avoided that clinic just based on symptoms.
Okay. Well, let's talk a little bit about, we've gotten to the point where we're feeling somewhat confident. And I keep reiterating, we want to be somewhat confident. We don't want to just, go in there with the arrogance. I know what you have.
Right.
I always try to say, I think I know what you have.
Exactly.
Let's say we believe it's a localized, uncomplicated, non-infectious, inflammatory dermatitis. We might start with something like a coconut oil or a vegetable oil or a moisturizer.
Oh, right.
You don't need to really jump in, fully. A lot of times these irritations can be due to the skin not being moist, not being sort of in a healthful state. Sometimes we'll even throw a calamine lotion. But this is a lot of times when you're thinking about your limited resources, when I like to talk to the local people in the areas where I'm practicing, what do you tend to use? And they may be taking a coconut that's not very ripe, and they may be using something like that.
Sure.
So it's always nice to know what are my local options before I start dipping into the resources maybe we've brought to an area.
Exactly.
Usually I recommend when we get to our next level where we're starting to use some of our low potency steroids is putting it on a small area and then seeing a test area, a small test area.
Got it.
Does it get better? And then if they say, oh, it got better,
Right.
then starting to treat a larger area.
Very good.
And then just as skin in general, keep the area
Of course.
healthy, keep it dry, don't scratch it, avoid irritating the area.
Yeah.
But then we run into the issue, what if it's more significant, really irritating, it's diffuse and driving them somewhat crazy. I still would start with the coconut oils, the vegetable oils, the local remedies, which can actually be quite helpful. You may want to do a little more with your steroids. You probably want to be careful as you go up to higher potency steroids. It is very rare that I would ever use an oral steroid in these settings. Particularly if I'm in an area where maybe there's strongyloides, where maybe there's some other underlying issues where if I immune suppress somebody in a context, let's say like the tropics or limited resources where maybe they don't have easy access to care, where you can create much more harm than you initially encountered. Sometimes we'll use anti-itch medicine, like our diphenhydramine. For children, we might use solutions, liquids. As we get older, we might start using tablets, things that allow them to stop scratching while the area heals.
Sure.
So
my Rolodex was turning while you were saying some of that, and I do recall an incident.
Excellent. I look forward to this. Please share.
Anecdote number 233, perhaps. No, I spent most of my life working in the laboratory on a parasite, and I used mice as my host. And I became allergic to mice, to dander, to the mouse dander, and also to mouse urine. So I had to cover up all of the parts of my body that would be exposed to those elements, including wearing a mask, and in some extreme cases, even a hairnet. And I can recall one incident where I was infecting the mice with all the precautions. But to do that, you take them out of the cage and you put them into a bucket. Out of the cage into the bucket and put them back in the cage. And you do the next cage into the bucket. Well, The bucket was then washed in hot, soapy water. And I was in the next room talking with someone on the phone after I had finished my work. And the allergens from the bucket vaporized and came around the corner and induced in me what you would probably classify as an anaphylactic reaction.
Okay.
And I couldn't breathe out.
Mm-hmm.
I could breathe in, but I couldn't breathe out. It was closing off as I would expand. Nothing was working in the other direction. And someone actually had to run down the hall to the Department of Dermatology and get a couple of tablets of, in those days they were giving chlortrimetin, but I could probably say it was another steroidal type of anti-inflammatory. And I absolutely took those, and I have a feeling that saved my life, because I was really exasperated, not knowing what caused this.
Yeah.
But of course, the moment I walked around the corner and I saw what was going on, oh. And I never forgot how that felt, because it was probably the most helpless moment of my adult life, with a situation that I had no awareness of what the cause was. So that's an allergic reaction deep in the lungs. That's not on the skin or anything, but it relates very much to that, because if I had a drop of urine, that would have been a very large, localized, itchy thing that would have just driven me crazy unless I used someone used
Yeah, no, I mean, the immune system can be our friend. It also can cause us lots of discomfort.
No question.
And what you were describing, when we have a really exuberant immune response like that in the lungs, you can get what you were describing as air trapping, where you can still get air in, but when you try to breathe out, the airways are narrow. You would need to really take your time. It would take 2 or 3 times, maybe 5 times as long to get the same breath out as you might to get it in.
Right. You know what I really thought? I thought I was suffering from a heart attack at that point. That's really what was going through my mind. And thank goodness it wasn't. But
no, and it is interesting. We talk here about all the different diagnosis, treatment, but you went one step farther. You identified the precipitant.
Well, it was pretty easy once the culprit was observed firsthand, and based on what I was doing for the last 2 hours, it was obvious what the cause was. But
and that can always be a challenge.
Sure.
I think a lot of clinicians might get frustrated, and after a while say, I can never figure out what it is.
Exactly.
Because things change. It might be a new detergent. It might be a new soap.
Exactly. Or darkroom work. People working in the darkroom, where they're exposed to these photochemicals. Those people can become allergic to these photochemicals very rapidly. And if they don't wear gloves, and if they just put the papers in, we don't do it that way anymore, but we used to, lots. And I'm sure that a number of people came and, "Doc, my hands, look, the skin is just falling off. What's wrong with this?" Well, what do you do for a living?
Yes.
And that has a lot to do with contact dermatitis.
And I use the term contact dermatitis.
Yeah, well, that's what I used to call it.
Yeah, which is actually, that is a large portion of this, is you have come in contact with something, your skin, your immune system is now responding.
Exactly.
As if it were an infection, as if it's something that needed to have a big immune response targeted. And so when you're going through, you may start asking, what do you do for a living?
Exactly.
And maybe they're doing something that involves lime, and they got lime juice, and now that sensitizes their skin to sunlight. So sometimes it can be a little more complicated. And you're only going to have so many of your tubes of cortisone cream and so many pills of your diphenhydramine, or so much liquid. So ideal is looking at the big picture, taking the extra time to maybe figure out, why does this person have the inflammatory, and how do we avoid it? So that is the ounce of prevention is worth a pound of cure.
Yeah.
And I think that, so for you, what is it, an ounce of prevention, staying away from all the mouse urine and dander?
You have to create a barrier between you and the cause. And to do that, sometimes it requires going a long way. You almost have to look at it as if you're doing barrier medicine. So you've got a patient in the intensive care unit, and you change your gloves, you change your gown, you change your mask every time you go in and out of the room. And that's the way I treated my mice because, not because of what I was doing to them, but because of what they were doing to me.
All right, well, I'm sure most of us have either seen this or we've taken care of individuals that have experienced this. So just to reiterate, always be very careful because we want to make sure that we're not calming down the immune system when the immune system should be doing something to protect us. Follow-up is really critical.
Yep.
And whenever possible, try to get at the root cause so that you're not just masking symptoms, you're actually preventing them from developing.
Sounds good to me.
All right. Well, thank you for joining us again.
Yeah, we'll see you next time.